the great show every week where we talk about the amazing topics in infertility and review all of the hot topics and interesting news that's out there for you guys, bring out the truth, help empower you to make good choices and to hopefully save you time, effort, and a whole lot of money. So we always take a few minutes to let everyone get on board, and we're going to do that tonight again. Take about 5 minutes, grab your popcorn or whatever you like, and some kind of snack, a cup of coffee, tea, hopefully something healthy, and we'll get started. Just let everybody join on. Hopefully you've all been having a good week. We are getting busier and busier. Embryos have very slowly started trickling in, and fertility centers have started up again slowly. So we're getting everything up and running as quickly as we can. We are still waiting for the College of Physicians and Surgeons of Ontario to do our inspection, but hopefully they'll be up and running shortly as well. And we are getting some embryos at, unfortunately, a much slower pace than we'd like, but they are starting to come in. And in the meantime, loads of consults, reaching out to everybody, trying to help everybody out, Canada, the US. Just found out tonight that 35% of the people watching our show on YouTube are actually watching from California and Texas. So hello to all our Texas and California friends. It's great to have you guys on board. And I think we've got enough people signed on here, so we can probably get started in a couple more minutes. Just letting a few more people sign on to join. I guess most of you hopefully are in phase 2, wherever you guys live. So slowly getting back to work and increasing the size of your bubble so that you can accommodate more people in your household. And friends and family, of course, as well. So that's really hugely important. We obviously want everybody trying to get back to normal, but please stay safe. You should wear a mask. You should still use protection. There are loads of places all across the States and probably across Canada as well, where there is a resurgence of the virus. So you do need to be careful, continue using precautions, continue using protections. And, that's really going to be important. There was an initial case reported of triplets born in Mexico where the babies were born COVID positive. They still can't figure out if it was from the birth sort of process or if it actually happened at the time or prior through what we call vertical transmission from mom to baby. So we'll have to see, how that transpired, but interesting. That's the first reported case of it happening like that. So I do want to give a shout out to a very near and dear couple. I don't know if they're watching. They had tried numerous different types of fertility therapy through us and had successfully achieved a pregnancy. Tried again and were unable, and after many struggles are pregnant again with a few extra little babies in there. So congrats to them. We will get you through this, and hopefully everything's going to go smoothly from here on in. So I'm sure you're still bewildered, but we'll get you through it to the end safe and sound, don't worry. Okay, so tonight's topic is an interesting topic, mainly because it was really big news a few years ago, and a lot of the places that were promoting doing the genetic testing like PGT were tacking on this additional test called a mito score or a mitochondrial DNA score. So mitochondria is the energy factory in your cell, and if you don't know this already, all of the mitochondria inside you actually come from your mother. So the father's sperm does not contain any mitochondria, which contributes to the fetus. It's all coming from the egg. And so the belief was if you have a variable level of mitochondrial DNA, maybe your egg is not as efficient, and so perhaps those embryos are not going to be as good. The theory being that if you had a low number of mitochondrial DNA, then the chance that the embryo is energy efficient is high. And so you don't really need any more, sort of energy efficiency or energy apparatus in there to help produce more sort of resources for the cell, for the embryo. Whereas if you had a high number of mitochondria, it probably means it's a weaker egg because you need a lot more of these little energy factories to produce what's necessary for the cell or the embryo to maintain its normal operations. So the theory was low mitochondrial DNA would probably be good, high mitochondrial DNA would probably be bad. And so people actually went off and started studying this, analyzing it, and determining, how significant the risks were, what the numbers were, and so on, and how much of a role this actually played in everything. So there are a number of studies for this, and most recently, Richard Scott, who is really kind of one of the smartest and brightest guys in all of infertility, he just published a study, or at least is in the process of publishing a study in Reproductive Biomedicine Online, and the article is entitled "Mitochondrial DNA Content is Not Predictive of Reproductive Competence in Euploid Blastocysts." Now, just to give you a comparison, last year, February, so just a year and a half ago, there was an article in Fertility and Sterility entitled "Mitochondrial DNA Copy Number as a Predictor of Embryo Viability." And their final conclusion is, as is common with new tools, this attention has led to both inflated expectations and serious disillusionment. Here we gather evidence to establish the true clinical applicability of this method. Controversy continues to surround this topic, adding both interest and confusion. So even a year ago, there were studies that were saying, yes, this is still good, and other studies just starting to come out that were saying, no, this is not that useful. So Richard Scott studied this in a very, very interesting way. And I thought I'd bring this to your attention because this is one of those things where sometimes you can end up paying extra for it. You might have to add in extra dollars to get this testing done. And the idea is that maybe you can predict which embryo is going to do better. And by predicting which embryo is going to do better, you're going to end up with a better result and a better outcome. So really the question was, how useful is this? And so Richard Scott developed this very ingenious study where he had sort of three different arms to the research project. Number one was just sort of validating the amount of mitochondrial DNA in each cell. So that's kind of boring scientific stuff. I won't get into that with you. It's not really important other than to say their method was validated. They made sure it was accurate before they went ahead and started running their study. The second one was to look at embryos purely that were euploid, meaning they had been tested and were genetically normal. And in those embryos, they were looking for the amount of mitochondrial DNA to see if it made a difference, comparing all embryos to one another. So our embryos to your embryos to the next person's embryos and so on. And then the last part of it was testing to see if sibling embryos were different in the mitochondrial DNA content when one implanted and one didn't. So let's say, Minnie Mouse went and did her IVF protocol. She made a bunch of embryos and they implanted one and it didn't take. And then they implanted another one from that same egg retrieval and it did take. They were comparing the mitochondrial content from those two embryos to see if there was a substantial difference. So really neat study because you're really diving deep into the basics here, deep into the information, and you're hopefully going to come up with an answer that provides people with very sort of formidable, rational data that they can help to use making a decision. So they looked at 615 euploid genetically normal human blastocysts used in single embryo transfers at a center called RMA in New Jersey. And Reproductive Medicine Associates is one of the very large fertility centers in the US. They have locations all over the place. And now they've merged with IVI from Spain. So I believe they're the world's largest IVF company. Richard Scott kind of heads it all. The man is an absolute genius. And he's a very bright and talented man running the show there. So basically, they said they had no restrictions on maternal age, clinical diagnosis, or number of previous attempts. So this was like all comers. But what they did exclude were people that had any endometrial problems where their lining couldn't be more than 7 millimeters, or if the blastocyst had to go up until day 7. So there is good data out there that shows that if it takes you till day 7 for the blastocyst to develop, the results are not as strong as what they would be if it's a day 5 or a day 6 blastocyst. So all of these embryos had previously undergone testing. They had the biopsies from the embryos, and they were then able to take those biopsies, reanalyze them for their mitochondrial DNA content, and then compare the two groups. So the very interesting parts of this, just kind of going over the demographics. Maternal age at the time of oocyte collection was anywhere from 21.8 to 45.3. So you've got the younger patients and you got the older patients. And they had a phenomenal rate of implantation. So this is a very, well-run organization. This is a high rate of success. Per single embryo transfer, they were getting 68.5% continued pregnancy at 9 weeks with a positive fetal heartbeat. So that's very, very good. So what they said was there was no association found between the mitochondrial DNA content and sustained implantation rates. So the statistical significance was not there. And it was not associated with other factors, for example, between maternal age at oocyte collection. So they didn't even find that the mitochondrial DNA content was actually related to your age, which is something that's being proposed many times, because what they've said is, as women age, you're getting those weaker eggs, and those weaker eggs will be the ones that are also less energy efficient. And if they're less energy efficient, then again, you might have a lower chance. Years ago, we had a company that was really big into this, and they're a very well-known company. And they actually were saying that this is a very critical test that we should do for patients, because they were grouping patients into quartiles, which is when you divide it into 4 separate groups. And they said that the difference in implantation between the low mitochondria and the high mitochondria was a 60% difference. So the ones that had high mitochondrial DNA had a 20% implantation rate, whereas the ones that had the low DNA content had an 80% implantation rate. So they were really promoting this, saying everybody should be testing for it. Well, Richard Scott's saying that doesn't even exist in terms of age, let alone between embryos. So they have this really interesting stuff, and I'm going to share the screen with you guys so you can see it. Give me one sec. For those of you on Instagram, we can't share, but I'll share the picture with you. So that's kind of the first graph that we're looking at, and it's just a scatter plot, okay? So in the pink on this side are the ones that failed, and on the blue on the other side are the ones that succeeded. As you can see, this is your mitochondrial DNA content. And for those of you watching on the other platforms, here's your relative mitochondrial DNA. Here is failure versus success for sustained implantation. You can see those scatter plots are basically identical. Doesn't matter what your relative DNA content was, you're still going to get the same number of failures and the same number of implantations. So then they went a little bit further and they ran something which in statistical reality is a really cool test, and that's called a receiver operating characteristic curve, or an ROC curve. So I definitely don't want to bore you guys with stats, but this is kind of a neat little thing for you to see. So let me pull this up for you. So an ROC curve plots the sensitivity of a test versus the specificity of a test, so that you determine where there's a threshold where you can say, okay, at this level of mitochondrial DNA, we're going to get this ability to predict whether or not the patient's going to get pregnant or the embryo is normal or whatever your question is. And what you want to see in a receiver operating characteristic curve, and this is the line they had, is the exact opposite of this. It should go up, go across, almost like straight up and across would be the best. So again, for those of you watching, you want this line to go straight up here and then across like that, okay? So it should rise right along the sensitivity scale, get to 1, and then go all the way across the specificity scale, meaning it's extremely sensitive and extremely specific, so it can rule in the normal number and it will rule out the abnormal. So in other words, if you had a specific threshold, let's say 10 copies was significant, At 10, you could say if it was less than 10, 100% of people are not going to get pregnant. And if it's over 10, 100% of people are going to get pregnant. So again, because it's this straight line that I'm showing you here in the graph, and you can see it here, that is indicative of absolutely no value whatsoever to this test. It's a match in terms of sensitivity and specificity 1-to-1, meaning it's totally non-specific and non-sensitive, essentially a useless test. So the final part, what they concluded from this was that there is no benefit to doing this test. They said it doesn't predict embryo viability, it doesn't predict implantation, it didn't even predict blastocyst formation as far as they could tell. Now, it does have some problems with the trial. Number one, it is retrospective, so they went backwards and looked at embryos that had already implanted, already been biopsied. It's always better to run this stuff in a prospective trial. Number two, they were looking at this from the standpoint of just the questions that they were asking, and they weren't looking forwards to see, hey, does the mitochondrial DNA content affect how quickly it forms a blastocyst, or how long it takes to reach the blastocyst stage, or how many of the embryos were euploid or not euploid. So those questions are not answered, but ultimately what they've come up with here is very, very convincing data that there is no difference between the two. Even when they did the sibling pairs, which are super interesting, they still showed absolutely no difference. So the two embryos coming from the same patient, where one worked and the other one didn't, they even had the same amount of mitochondrial DNA. The thing we need to learn from all of this, in addition to the fact that this test is useless and no one should do it, is that a lot of us, myself included, almost all the fertility specialists out there, we often want desperately to find something that will help you guys. And so when something comes out, we jump on board thinking this is a good thing for us. We can help, you guys by using this test. I can give you numerous examples. We've done many of them here on the show. The ERA test is one of them. Then they came out with Emma and Alice. There are multiple different things people try and suggest work that actually don't. One of the other ones is time-lapse embryo incubators. None of these things have ever been proven to be beneficial, but when they first come out, they've got this great sales pitch. They've got an amazing marketing team. They love that kind of blitzkrieg approach to inundating you with information. Everybody's doing it. You guys should jump on board. They get these really big clinics to try it, probably for free, and they say they're doing it. You guys should try it too. And we all want to help, plus none of us want to be left behind, so we tend to jump on board. So it's super important for all of us as REs and all of you guys as patients to be very picky about what you're doing. Don't just jump on board. Don't just dive into stuff that's promoted, because it doesn't always actually work. It's always worth trying stuff that the fertility specialist has experience with and says, yes, I've done this many times and it actually has been proven to have a benefit either in my practice or scientifically. But just jumping on board because some company is suggesting it's working is not a good idea. So the fact or fiction this week was, does mitochondrial DNA content predict embryo viability or embryo development or sustained implantation? It is a fiction. It does not predict anything other than a waste of money. So make sure you like, subscribe, and follow. We are desperately trying to grow our YouTube following, and we are getting bigger by the day. So make sure you let everybody else know about that too. And you can reach us on Dr. Victory, or you can search Victory Reproductive Care. Make sure you join us there. We do want everybody coming on board for that, and we will happily be able to spread the word. And if anybody has sort of promoted this for you, if you've already done it, that's great. It's not going to negatively impact anything, but don't judge which embryo you're transferring based on your mito score or your mitochondrial score. It's not actually predictive for anything. So with that, we're going to start taking some questions. Do you want to start with yours, or should I start with mine? Or
you start, Mohammed.
Okay, so Dr. Victory, any updates on funding? Yes. So with regards to funding, we have finished the letter and that we are using as a news release, and that's going out tomorrow. That is tomorrow, right? Right. So that is going out tomorrow, and we've already got about 7,500, I think close to 8,000 people that that joined our petition online at change.org. So we are hoping with that we will be able to get some funding. We do have a minimal amount of funding thanks to the amazing people at Create Fertility in Toronto. So we're going to use that as well. And I am working on as many options as I can to increase our access to funding in the meantime. Hopefully between Tarek and myself and some local politicians, we'll be able to get what we need to make this work very, very soon. Any updates on embryos coming from Nahal? As I mentioned at the start of the show, embryos have started coming from Nahal. They have started shipping 5 per week, and we were able to bring down the cost. So that's good as well, and we are working desperately to get those over, but I am rate limited by my companions at Nahal, and we are kind of beholden to what they do. So if they want to make us wait, then we have to wait. And right now, they feel that they are limited to doing 5 per week because of safety concerns. So I certainly don't want to jeopardize anybody's safety, and if they're telling us it's 5 per week, then it's 5 per week. Might be a dumb question. If I took metformin and baby aspirin during my first pregnancy, how soon prior to a transfer would you recommend starting on that medication again? So I would definitely recommend staying on metformin forever. You don't need to come off of it. Baby aspirin, you can start maybe a week or so before the transfer, and that should be plenty. Usually at least 2 weeks is even better. But any time around then is good. Just don't start it after. A lot of the problems with the data on aspirin is that it was started after people found out when they were pregnant. And the whole point of aspirin is to counteract thromboxane and prostacyclin. And those are the 2 agents that actually set you up for problems in pregnancy when the embryo is implanting. So if you're waiting till after the implantation has occurred, you've already missed the boat. And that's why a lot of studies don't show a benefit. It's because they didn't start the aspirin before the patients actually got pregnant. I am 5 months pregnant. When do I stop taking aspirin? Don't stop taking aspirin if you're already pregnant and you're on it. There's no risk to baby, and it's perfectly fine for you to continue. Okay. I had a monitoring appointment booked, but had a positive ovulation test. Is it safe to say my monitoring appointment is canceled and I can just come in for the IUI? Yes. So if you did a positive ovulation, you should just notify us that day. We want you to take a trigger shot, which is Ovidrel for us, but you can use any kind of trigger shot, HCG or Ovidrel, Pregnil, they're all the same. And then that will increase your chances of success. And we did a fertility factor fiction on that a few months ago, I think. And basically, then you call us and say, hey, I'm ready for my IUI tomorrow. You come in the next day, and then you just have to choose if you want the conventional method or the new one, which is called Zymo, where we use a microfilter pore, and it helps screen out some of the DNA that are not as good. Some of the sperm that have not as good DNA. So that's really important too. Okay, let's see who all is asking stuff on Instagram. Where are we here? Okay. When your LH is slightly higher than your FSH on a day 3 blood draw, does that mean PCOS? Frequently it does. So if your LH is higher than your FSH, it means that the stromal, kind of the meaty component of your ovary, is thicker than the follicular part. And so that can lead to extra LH production. And if that's the case, that's typically what we see in the PCOS women. Metformin will actually drop your LH levels, so that's a really useful technique. And then Clomid and Letrozole can also do that. We do believe strongly in using some of the supplements, so NAC and inositol. And then in addition to that, lifestyle factors if you are not the thin PCO patient, because 10% are very thin. If you're not in that 10% group, then you definitely need to eat 6 meals a day, and you must exercise using hardcore exercise, muscle building, not just taking a walk. You actually have to build muscle in order to get your aerobics up. Whoops.
I have a question if you want.
Sure.
I'm wondering if there is any downside to doing a zymal sperm prep for IUI, wondering why there are different options for this since it only makes sense to do this.
Yeah, so there is a different option, and the option is to do what's called a conventional sperm prep, which with us is a centrifugation through a gradient. Okay, so let me explain that. So we have a test tube, and there are two chemicals, which are a gradient of thickness. So think kind of like honey and oil or something like water and oil, okay? And basically what happens is those gradients prevent some abnormal sperm, a lot of the dead sperm, all of the proteins and debris, and almost all of the ejaculate from getting through. And at the bottom of the tube, after you've whirled around in a centrifuge at 1,000,000 miles an hour, you get just the sperm. And then you take the sperm and then you rewash it in a Red Bull for sperm, as I like to call it, and then you recentrifuge that, and then you take that and you put it back in more of that Red Bull for sperm, and that's what we inject. So there are two reasons to do that, I guess. One is it's way cheaper. Unfortunately, the Zymo costs us more. We needed specialized equipment for it, including this special little mini incubator. And the plates themselves are quite expensive to use, plus all the technology and the fluids and all that other stuff. The second thing is it's not necessary for everybody to do the Zymo. Yes, there are studies that show it improves success, so I support it. That's why we use it. And yes, for guys that have high DNA fragmentation, there is no question you really should be using the Zymo. But you don't have to use it. And if you want to save money, I'm a big proponent of saving money. So I don't want you wasting money if you don't need it. So if your DNA fragmentation's okay, the sperm's okay, your main problem is, for example, your cervix is tight, you don't really need the Zymo, so you don't have to do it in that circumstance. Sure, fire away.
I read that ibuprofen can inhibit ovulation as this is an inflammatory process.
Yeah.
Would the aspirin inhibit that process as well?
No. So aspirin's okay, but ibuprofen can inhibit your ovulation. So do not use ibuprofen or any non-steroidal anti-inflammatories except aspirin. Aspirin is safe. None of the other ones are. I've got one here. At 30 years old, my FSH is 8, which from my understanding is a bit high for my age. My AMH came back at 20.2, and I had an antral follicle count over 20. What does my higher FSH mean? I am breastfeeding, I think it says. Whoops. Yeah. So it means nothing. It means absolutely nothing at all. So first of all, when you're breastfeeding, no one should be checking your hormones because they don't mean very much right now. We can check them if we're looking for other stuff, but it's not going to tell you very much. Your antral follicle count and your AMH are awesome. I'm sure many of the women here online watching with us now wish they had AMH and antral follicle counts like that. So you have absolutely nothing to worry about. Your FSH is actually normal. FSH is not very sensitive or specific for predicting fertility. However, we don't even get nervous about it till it's over 12. So if you get your FSH over 12, yes, we start getting concerned that the ovary is becoming a bit weaker. But if it's less than 12, there's absolutely nothing to worry about. And whether you're 11.5 or you're 6 or you're 4, it makes no difference. So don't pay attention to your FSH level. It's not critical. Do you have one there? I've got one here.
Right.
Is there any opinions you have on the accuracy of blue dye pregnancy tests? I'm not sure what a blue dye pregnancy test is, Judy, but if you just mean the sticks, like the urine sticks, they're about 97% accurate. So 97, 98, depending on which brand you buy. And to help you guys out, Tarek and I are going to work on doing a review show where we buy a bunch of kits. And we're actually going to get someone's pregnant urine and dip them and see which one shows up positive the best and the fastest. So I think that'll be a really cool review show to do. Maybe we'll do it in place of a fact or fiction and then go into the questions with you. So we'll do that soon. Let's do a Facebook page. Oops, sorry. Go away. Okay, we can get that one off. That's not important. Okay, so My husband and I have gone through 2 cycles of IUI, 2 cycles in a row, but with me going back to work in July, probably going to have a hard time getting off for appointments and the stress of going back. We talked about waiting for our 3rd attempt with IUI for the best outcome. Will this cut my chances of it being successful? Not doing 3 IUIs in a row, or no? Thanks for all your hard work. No, not at all. Waiting will not cut your chances in half. Your IUIs do not have to be in a row. It's the same chances individually each time. There is a cumulative benefit to doing IUIs up to about 4, and then after that it actually starts to decrease a little bit. So as long as you're doing them, you're fine. You don't need to do them back to back, sort of month after month. That's perfectly fine. Don't worry about it whatsoever. Let's take the next one. Besides prenatals, do you recommend any supplements or vitamins for my husband and I to take a couple of months prior to starting to conceive? Yeah, so absolutely. We talk about this every show. Okay, so women should be on a prenatal vitamin, ideally with 5 milligrams of folic acid. You want to be on vitamin D, at least 2,000 units a day. And you definitely want to be on as many antioxidant vitamins as you can. So Coenzyme Q10 is helpful. For those who have a lot of inflammation, you might want to try the NAC or the inositol for supplements. There are loads of vitamins you want to take. Mediterranean diet is good. Some exercise, healthy diet. Make sure you keep your cholesterol and your sugar intake low. So all those are very helpful things from the female perspective. For the guys, to be honest, the easiest thing to do is just take a male fertility vitamin. I own no stock in any vitamin company or anything like that. We use YAD products, which are a Canadian company. They're great. Their service is awesome, and they're really inexpensive compared to some of the American ones. So you can get them in the States. You can get them in Canada. They do a great job. The ones for the guy are called Fertile Pro Men, Fertile Pro MTL for motility, and then they have another one called Ubiq, which is just ubiquinol, which is coenzyme Q10. So those are great fertility vitamins to promote for men and help for their sperm production, their sperm quality, their sperm performance. There is one that's also actually Health Canada approved, and I don't know very many vitamins that are Health Canada approved, but this one actually is. And instead of being called Fertile Pro, it's called Pro Fertile, just to make it maximally confusing. It's from Austria. It's a fantastic product. It works very well. It is a little bit more expensive, but it's a great product, and we have been really happy to use that as well. So when the guys want something even stronger or they're failing the YAD, that's what we put them on, and we try that. Okay. Here's a good question. So do I recommend doing another ERA before another embryo transfer if it's a few years apart? So Lorena, we don't do ERA tests anymore because the data now shows that it's useless. And I just got asked this the other day by somebody who then went and watched our fertility factor fiction and decided against doing it. The ERA test is not useful. We used to think it was really helpful. It actually is not really helpful. So do not bother doing another ERA. It's not of any use. When will my clinic be open? My clinic is open. We are open now, and we can help you out, even when you're coming all the way from Winnipeg. So we're more than happy to help you guys out. Just give us a call and we can help you. What else do we have? Leading up to the birth, what month do I stop aspirin? You don't need to stop aspirin. You can be on aspirin right through till the birth. It's perfectly fine. Some anesthetists get a little bit nervous when patients are on aspirin and they have to put in an epidural. I'd say probably 30–40% of my population is on aspirin and they've never had a complication from an epidural. So I'm not worried about it at all. But if you are in a different hospital from ours, you may want to speak to your anesthetist first. Just ask for an anesthesia consult and they'll tell you if they want you to stop it ahead of time. Okay. I had my SIS, saline infusion sauna histogram, with you this morning. And I left without asking a question. My left ovary had only 4 and my right had none. Could my right be empty this month and next month it has follicles, or is it more likely I'm ovulating out of one ovary? I can't quite see the rest of that message. Is there anything I can take like DHEA to help? Thanks for everything. Yeah. So if one ovary has more eggs than another, then it's certainly possible the next month it'll reverse a little bit. It's a little more concerning when there are no eggs being seen and only 4 in the other, because that means overall the ovarian reserve picture is not as robust as we'd like it to be. So sometimes those patients definitely have a little bit of a harder time. They can't get the same responsiveness, and it's possible that one ovary is weaker than another. Specific circumstances where that can happen, sometimes we get women that have almost like a varicose vein look around their ovary. They have a lot of veins, and when they have all those veins, they're unable to cool the ovary properly. It gets overheated, the drainage backs up, and the ovary can't kind of get rid of its toxins, and so it can kind of die off faster. So there are some women where one ovary will not work as well as the other. We're definitely always happy to help you try, but it can be a bit more challenging when the ovary is weak. What works? So DHEA will help you make more eggs, but it has never been proven to increase live birth. There is some data that shows that human growth hormone will actually increase live birth. It is pricey and a little bit difficult to get a hold of, but yes, it does support use, especially in women that have diminished ovarian reserve. For those of you who are doing IVF, you can certainly try what's called duostim, and we reviewed that about a couple of months ago as well, where you're doing your IVF cycle, and then you do your egg retrieval, and then you wait 5 days and you immediately start another egg retrieval. So in those patients, they've done very, very well. And we just actually did one for the first time ourselves on a patient who had previously not done well, and she did great when we did it this time. We were really pleased with the outcome. So there are some real positives to doing that, and that's a very gentle approach that's very reasonable. It does require 2 egg retrievals. We actually dropped our price a lot to make it very reasonable for our patients. So I think that's a great approach for you guys to consider using, especially if your ovary's not super strong anymore. Let's take Instagram. My question is, does having a full versus empty bladder during IUI affect success? Yes. If you are crampy during your IUI because your bladder is too full, it will negatively impact your success. So we just need your bladder a little bit full, just so it kind of flattens out your uterus. If you're super full, it's not good, so don't do that. Just a little bit. A little bit is good. Too much is not good. What else have we got here? Could having chronic endometritis be the cause of multiple miscarriages? 100%. So there is good data that actually supports the fact that endometritis, or chronic endometritis, which is infection or inflammation of the lining of the uterus, can actually increase the chances of miscarriage, including later miscarriages. I have become a big fan of this new test from a company that used to be called Locus Medicus, and I think is now called Fertilisys, SYS, but you still get there by typing in locus-medicus.com. They're in Greece, and they do genetic testing of bacteria and viruses in the lining by doing what's called PCR, polymerase chain reaction. So they can actually detect if there are bacteria or viruses in the lining of your uterus. This can be very detrimental to people achieving success. So we have found that some of our patients who've had multiple miscarriages or recurrent implantation failures are actually screening positive for bacteria, and then if you treat them, in theory, and of course COVID has interfered with this, so we're not sure yet, but by treating them and eradicating whatever that virus or bacteria is, you can really make a big difference. Big example is human herpes virus 6. Studies can show that anywhere from about 37 to 41% of patients can have human herpes virus 6 when they're suffering from unexplained infertility. That's huge. So if we get rid of it somehow, then we might actually be able to significantly improve their chances without needing a whole bunch of treatment. So that's just one kind of aspect of this. And they can check for a number of different bacteria and viruses. So they have one called the Hidden C12-in-1, which is 12 of their tests. And I have no idea why they don't include human herpes virus 6. It's not included, so you have to tack that on extra. It is kind of pricey to warn you all in advance, but I think it's worth it for those of you that need that kind of testing. So you should do it if it's reasonable to do. But definitely if you have chronic endometritis, you need to get that treated. Why does metformin pills smell like goat feces? I have no idea why metformin stinks. I genuinely have no clue. We used to import a very, very strong product for Coenzyme Q10. So Coenzyme Q10 literally turns into gum when you take it. So you need a huge amount from most of the products in order to get a reasonable dose into your system. And so there's a company called Theralogics who makes a product called Neo Q10. And theirs requires 1/5 of the amount of everybody else's in order to get the same sort of dose and outcome. And people could not tolerate it because the smell was just horrendous. So I'm sorry that it stinks. I have no idea why. Make sure that you get yours checked to make sure it's not bad in some way. My partner had to postpone DNA fragmentation test because he has pain while urinating. He's going to GP for treatment. When is it okay to do the DNA fragmentation test? Should be okay. The sperm's stored in the epididymis, so unless he has epididymitis, it should be okay to go ahead. They should be able to tell that if they examine his testicles. If his testicles are sore, the epididymis is sore, you gotta wait at least 3 months after he's been successfully treated. But if the epididymis is not sore, it's just a urinary tract infection or a prostatitis, you should be okay. You can do the DNA frag anytime you want. Is it normal to have a decrease in AMH after an IVF cycle? Mine was 27, and then when rechecked 2 months later is 23. Jess, there's not that much of a difference between a 23 and a 27. They're both really high, so I'm not worried about that. And if it was just 2 months later, you probably have depleted some of the eggs. It might take a little bit to recover. And AMH is not like super flat constant. It can go up and down a little bit, certainly between 23 and 27. That's within the lab error range. If you send the same person's blood twice, even on the same day, you'll get different AMH ranges. So it's not that accurate, and I definitely would not be concerned if you had a 23 and a 27. Those are both really good. Oh, here's a good one to show. Does PCOS cause false positives with ovulation tests? If so, how can I track my ovulation? You can't. You need us. So if you have strong PCO and your LH is high, you will chronically show up positive on an ovulation test because those ovulation tests are picking up a breakdown product of LH in your urine. And because of that, it's not actually going to be a useful test for you because it's always going to be positive. So for those patients, you need to come in. We need to do ultrasounds. We need to do blood work. That's the only way to figure it out. So that's a great question. That's why I wanted to share that off for the show. If I wanted to do a donation for myself when the time is right, can I do it with less medication and injections? Or will that not give me good results? I'm sorry, but I have no idea what you mean by donation. If you're donating your own eggs, you can do it with less, but it takes a lot of frozen eggs to achieve one success. So that's probably not a great plan. If you're talking about sperm, I'm not quite sure how that would follow, so I'm assuming you mean eggs. But yeah, let me know what you mean by that and I'll answer the question better. Due to the current restrictions of only allowing the patient in the office, is it safe to assume I am to bring in my husband's sample for my IUI with his signed paperwork? Yes, you can either bring your husband's sample in, or better is he needs to drop it off because we really need to see his ID. So have him drop it off and then you can come in after him. Our embryologist is very strict about wanting to make sure that we have validated that it is your partner's sperm. So we do need to have him there with his ID in order to validate that it's him. And we love our embryologist and we want her happy. She's amazing. So we will keep that going. Botox and filler during treatment before a positive test. You mean you got Botox and filler before a positive preg test or during treatments? Do not do that. You can't take Botox while trying to get pregnant at all. And filler probably doesn't have much of an impact, but definitely you should not be putting anything like that into your system. Botox could potentially be harmful, so do not do it while you're trying to conceive. 100,000,000%, that's a no. That's like a really hard no. Is coenzyme Q10 safe to take during pregnancy? If no, should you stop taking it during the 2-week wait? Coenzyme Q10 is in everybody's body. It's actually really important for the function of your mitochondria, which we were talking about earlier on in the show. So you've got it in you. Taking more of it is not going to harm anything in any way. If it makes you feel good, keep taking it whether you're pregnant or not. That's absolutely not any kind of a problem. Whoops. I'm writing stuff I don't want to. Okay. So if same question as before. So if my FSH is 8, but my LH is 9 on day 3, is that likely PCOS? Yes, it may be. It depends on the whole picture. So PCOS is a clinical diagnosis. We don't do it based on numbers. We do it based on your clinical symptoms. So irregular periods, hair loss from your scalp, hair growth in places where it doesn't belong, lip, chin, belly, chest, thighs, and so on. We look for irregular periods. We look for central obesity. So, oily skin. There's a whole host of features that go along with it. Insulin resistance, the LH, the FSH. And then there are some characteristic features on ultrasound as well. So it's not just one thing. We really look at the whole picture, but it's a clinical diagnosis. It's not based on your hormones. So don't get stuck in the idea that you have to stick with just the hormones for testing. Here's a really good one. I'm going to show this. Do you know of women with PCOS have a higher risk of heart disease? Yes. Women with PCOS do have a higher risk of heart disease because they have a much higher risk of diabetes, and women with diabetes have a higher risk of heart disease. In addition, many women with PCOS have something called metabolic syndrome, where you have insulin resistance, high cholesterol, high blood pressure, all of which are independent risk factors for cardiovascular disease. And I'd say the vast majority of women with PCOS, in particular when they are not the thin PCOS group, have family histories as well of diabetes and heart disease. So yes, if you have PCOS, you are at a higher risk. It is very important, therefore, to maintain appropriate weight, appropriate healthy eating habits, all of the antioxidants, all of the supplements and the vitamins. We really want you guys staying healthy. And it's a multi-pronged approach. Do not listen to anyone who just says, oh, you need to go lose weight. It is not about just losing weight. That is not the case. Yes, weight loss is important if you are not in the thin PCOS category, but it is not the only thing. You need medication, most likely metformin plus minus letrozole or Clomid, letrozole being a better agent to use. That's if you're trying to get pregnant. If you're not trying to get pregnant, you need the birth control pill. Failure to have regular periods increases your risk of cancer. You cannot do that. You must have regular cycles. So make sure you're having regular cycles at all times, or else you're going to run into trouble. In addition, you want the supplements. So the NAC and the inositol, we know that those are beneficial, at least in small studies that have been done, and there's no downside to them. So I strongly support that for the natural approach. And then for the lifestyle approach, it's healthy eating, which is 6 meals a day: breakfast, snack, lunch, snack, dinner, snack, low calories, very, very low carbs. And then you absolutely must exercise. And I say this every time, I'll say it again. Walking is not exercise. You need to do an exercise routine. You need to lift weights. You can use gravity, do plyometrics, but you must do something really aggressive to build muscle and burn fat and get your heart rate up and sustain it up. Walking will not do that enough. Okay?
I was walking yesterday.
You were walking yesterday.
I thought I was exercising.
No, buddy, you weren't exercising. You got to come to my place. The kids have set up a whole gym. My boys were actually on TV tonight because they went to an outdoor gym. And so, hi, boys. I saw you on the news tonight. That was pretty interesting. My progesterone went from 0.8 to 17.5 in 1 week. All I got told was cancel everything. Why? So it depends on what the background for that is, and the units. But if your progesterone went up to 17.5, it likely means you've released an egg. So it would very much depend on what you were doing and where you were in your cycle, but that can very much mess with what someone's doing. So for example, if we're going to transplant an embryo into you and your progesterone spikes, we completely ruined the timing and the synchronization of your embryo with your implantation. So that will cancel a cycle. So if that was the case for you, you absolutely need to be really careful about that because it won't work if they try and transplant the embryo. Facebook. I had my first IUI on medications and monitoring last cycle and it was negative. Sorry. We are trying again with the same protocol this cycle. Do our chances of pregnancy get higher with every cycle? Yes. So as I was saying earlier, up until about 4 IUI cycles, there is a cumulative increase each time in success because we learn a little, we tweak a little, and your success rate does improve. At least that's what the studies have shown. But then after 4, it actually starts to decrease. So that's why we tend to cut people off after 3 or 4 maximum. So that's important. Highly recommend T25. That's what I recommend to everybody. Kills you, yes it does, but it feels so good after. The best recommendation you made to get your butt kicked and likes to feel like Jello. Yeah, so I am a big proponent of doing focused T25. I did it myself and was probably in the best shape of my life afterwards. My knees killed. You do need very good running shoes, but it requires no equipment. And you just need a hard floor and get really good running shoes, like invest, whatever you need to pay to get the best, most cushy running shoes you can to protect your knees. But you're basically just jumping up and down for 25 minutes with no break. So that is real exercise, like just getting through that in those last few minutes. First, 3 minutes, you're fine. Then the next 20 minutes, you're dying. And then the last 2 minutes, it's like, oh my God, please let this end. So it's tough. It's really brutal, but you will get ripped in 90 days. And I've done it myself and it worked. It totally worked. If I hadn't killed my back recently, I'd probably be doing it again now. So definitely do not try 225-pound deadlifts. Bad idea. Advice for day or days after FET. Yeah, don't do anything too strenuous. Continue to have sex. We showed that on the show that having intercourse can actually help. Nothing crazy though. Please don't swing from the chandelier, as I like to say. Not the right time to break out the 50 Shades of Grey kit. So yeah, gentle intercourse, normal activity. Avoid the extremes. No extreme temperatures, so no hot tub, no jacuzzi. Don't dive into a freezing cold pool. Try and just take it reasonably easy, but normal. And then, the things that can help you relax are important. So whether it's acupuncture or meditation or prayer or whatever works for you, maybe it's a support group or a blog or joining us here. Anything that helps relieve your anxiety, that's something you should do because it will improve your success rates. Low stress is really important, and that's why we've developed such a robust program for our patients with our whole secondary backup system. So we have the naturopath, have our psychologist, our social worker. We've got the online program, Organic Conceptions. Now we have a nutritionist doing stuff for us all the time. We even have an addiction specialist. And we have our amazing family doctor, Dr. Carrie Meyrand, who's willing to do counseling for patients in Ontario who don't have coverage for counseling, but are willing to see a family doc. So we've got all sorts of people to help you out. Anything you do to reduce your stress will improve your chances. Hope I was able to indulge in some desserts today. Oh my God, I love you. They were amazing. We were inundated with desserts today and they were absolutely incredible, like some of the best I've ever had. So thank you. I love you for that. You're a sweetheart. Straightest, fastest way to my heart is through my stomach for sure. I get ovulation pain almost every month, but only on the left. Does this mean I never ovulate from the right ovary? Oh, that's a super cool question. I don't know, but we could just monitor you once and see. Not necessarily. It could be that there's endo near your left ovary or adhesions. Some women's ovaries are more sensitive on one side than another, but if you get ultrasounds, you'd be able to tell which side the egg is growing on, so you'll know if it's alternating right and left. But, you know, if you're getting pain, it may be that there's endometriosis there, so that might be worth looking into. Wow, amazing. My ex-doctor was definitely crazy, lol. That's funny. I'm sorry you had a crazy doctor. Is there anything we can do to improve our chances of success with IUI in addition to letrozole? Sex every 2 days, sex around the time of the insemination, loads of vitamins, avoid everything bad, so no smoking, no drinking, no drug use, especially for your husbands. Use the Zymo, it does improve the chances. Make sure you use the trigger shot, even if you're natural or letrozole. Boost up to shots instead of letrozole. That's a big jump forward. That's pretty much it. There isn't a whole lot else. Again, naturopathic assistance, low stress, those sorts of things can help. There is a study that has not yet been published that I got access to, which showed that the only thing that was important when doing IUI, and they looked at thousands of cycles, was the count, like the total motile count, and whether or not there was pain at the time of the IUI. So super interesting findings and really important in terms of what catheter we use and when we actually do the INSEM. We always wait until the patient does not have cramps before we do the insemination. If you inject the preparation in when the patient is cramping, the uterus is doing this and it's just waving out the sample and it's pushing it right back out of the uterus because uterine contractions are directional. They are designed to expel whatever is in the uterus. So it's directing it back out. So all the stuff you just put in there is coming back out. So you got to be cautious. Okay, last couple of questions. Thanks for answering. I have no symptoms of PCOS at all. I was wondering because they said I had a polycystic ovary over 12 on 1. That's not a polycystic ovary. And now my LH higher than FSH. Wondering what's going on. We got to check you out. I mean, it's a holistic picture. No one even agrees on what the definition of PCOS is. So it's really, really important that we look at the whole picture and never say, you know, 100% it's this or that. Sure, there are very clear-cut pictures of PCOS, but PCOS is actually a spectrum disorder where you can have it really, really mild where you're actually thin. You maybe get a regular period even, but you get some acne and hair growth and you have a lot of eggs. So that would be like the real sort of entry-level version of PCOS. And then we have the extreme level where women actually look like men. They've got a full beard, they're balding, they're very heavy centrally, and you know they become diabetic and are very high risk. So you can get the extremes, you can get everything in the middle, and then there's that whole category of the thin PCO patients, which is different. So super important. If you thaw an embryo and then the cycle gets canceled for some reason, can you refreeze it and have it still survive? Okay, so no one should cancel an embryo transfer after the embryo is thawed unless they had trouble getting into your cervix. You can actually refreeze them and rethaw them. We don't love doing that, but the experts that do it say it really doesn't make a difference. I'm not convinced. My embryologist says it's okay and the success isn't as good, but you know, that it works. So most people would agree with her, and she's a really bright lady, so I always agree with her too. But nevertheless, it's not something we aim for, but that really should not happen. And if it does happen, it's extremely unusual. Okay, it's 8:59, guys. I love you all. It's been a great show. Thank you for joining us. Remember, subscribe to our YouTube channel, like, comment, share, and always send your questions. We are more than happy to join you guys for more questions anytime we can. Share this with your friends, bring them on board. We will love to have more people. We really want to grow the show. There are thousands of people now watching the YouTube videos, so let's see if we can get them more on live. That'll help generate more interest and more sort of questions and answers and scenarios so we can reach everybody out there. Have a great night, guys. We hope you all stay safe and be well. Take care.